Break is over. Our next panel contains a wealth of expertise and experience. To keep us on schedule, I'd like to introduce our moderator, Dr. Ron Winder, and let him introduce our panel members. Dr. Winder is a past member and president of the Medical Board of California and is currently a medical consultant for the board. He is a professor of anesthesiology and academic chair, co-director of research, and clerkship director of residency at programs in anesthesiology at Cedars-Sinai in Los Angeles. And he's a practicing anesthesiologist at Cedars too. Please join me in welcoming Dr. Winder.
Thank you, Linda. You'll have to excuse me. I'm just getting over laryngitis. I'm not quite this froggy most of the time, but it is what it is. I'd like to make this as interactive as possible, and it's a terrific opportunity. We have some real experts in the field with us today, and I'd like to start to my right and have each one introduce themselves to you, starting with Dr. Greenberg.
I'm Dave Greenberg. I'm an addiction medicine physician, and I already introduced myself, or was introduced just moments ago in my talk, so I'll go ahead and pass to the next.
Howard Rosner. I'm an anesthesiologist on the staff at Cedars-Sinai Medical Center. I'm the medical director at the Pain Center at Cedars-Sinai, an associate professor of anesthesiology, and the director of fellowship program for pain medicine.
Hello, I'm Greg Paulson. I'm at the University of California in San Diego. I'm assistant director of the Center for Pain Medicine down there.
And I'm Darlene Fujimoto, and I was already introduced.
Shane DeSouza, I'm supervisor for LA County Department of Health Services, overseeing health policy and medication management.
My name is Dr. Jorge Carreon. I am an obstetrician and gynecologist by training, and I am a former member of the medical board. You will ask what is doing an obstetrician and gynecologist in this panel of experts, and I will share with you why. As a former member of the medical board, I review cases where I was extremely surprised how a young doctors addicted to fentanyl, propofol, and Demerol. And also at the same time it happened a personal experience that a classmate of my son in college, he died of overdosage of Xanax and alcohol. That is why I really became interested in this. And I went to the very Ford Institute to learn what is addiction. That is the reason why I'm here.
Introduce myself. I'm David Copenhaver. I'm on faculty over at UC Davis. And I'm a board certified anesthesiologist and pain specialist there.
Dr. Mahajan.
I'm Gagan Mahajan. I also work at the UC Davis Medical Center, Department of Anesthesiology, also board certified in pain medicine.
Well, we're very fortunate. I guess we need a bigger table, but we have an excellent group here. I'm going to start the first question. What are the differences between addiction, pseudo-addiction, habituation, and tolerance? It's open to anyone who'd like to start with that. Howard?
Well, since the title of the panel is Your Patient's an Addict, Now What? I think that we really have to establish why we suspect that a patient is an addict before we decide to pursue that line of reasoning. And so if you look at a patient as being drug seeking, why are they drug seeking? And they may be drug seeking for very legitimate reasons. They may be drug seeking because they're under-medicated. They may be drug seeking because they have become tolerant to the medication dose that they're on. Or they may be drug seeking because they're on a short-acting medication, and every time the medication hits a half-life, they start to withdraw. So the scenario of pseudo-addiction is a patient who is withdrawing every several hours on a short-acting medication and seeking more medication to treat that withdrawal. Of course, tolerance being patients with escalating requirements over time because their dose is not treating their pain. And so I would pass the torch to someone else at this point.
Yeah. Go ahead.
I think that addiction, until recently, is being recognized as a disease. When I was in my medical school, if somebody told me that this patient was addicted, I thought, and everybody thought, that was a moral issue. And today we know that it's a disease. It's a disease of the midbrain that can be treated but cannot be cured. I like to compare when I give my lectures to diabetes. Diabetes also is a disease that can be controlled. It's a chronic disease that can be controlled but never can be cured. That is how addiction is seen today by the experts.
Any other comments?
Just to reiterate what Howard was mentioning is that addiction does have this kind of phenomenon where you have a prospective pattern where there's no real blood test to determine addiction, and to kind of incorporate what Dr. Carrion was saying was that yes, it is a disease, but at the same time, there are certain aspects about that disease that allow for you to determine some risk factors associated with that. And just kind of as that prospective disease kind of unfolds for the practitioner, as you trial, if you may trial opioids, you may observe that the use of a medication despite self-harm is one of the quintessential philosophies associated with addiction. In addition to that, the compulsive nature of seeking the medication, and then there's a lot of that prospective data that's gathered. So I think incorporating all these ideas from what has been discussed today, documentation, studying your patients, these medications were typically misconstrued as safe, and the thought process being that when given, they should be given in the form of a trial, and then subsequent to that trial, you're observing data from that patient to see how they behave while taking them. That's helping you to gather some information regarding the potential for addiction.
We have quite a group of excellent pain docs here, so I think this is a perfect question. What is the appropriate medical care for a chronic pain patient who is really addicted to opioids?
Sure. I'll give my 2 cents worth on this one, but I'd also like to add a real simple thing about the previous question is that the more you can corroborate a patient's story, the better. And I always like to have the spouse or the significant other or an adult child or someone else there. And a lot of these patients don't want that to happen. Can I just say, no, I need to see you with your spouse or an adult child or someone who really knows you. And the patient may be telling me that his Oxy 30 tablets, that he takes 3 of them 6 times a day, that's really helping him in his life, and that he's just about ready to get a job. He's been on interviews and he's doing volunteer work at the church, and his sex life with his wife is much better, and he's parenting the kids much better, spending a lot of quality time with them and stuff like that. And I'll tell you that when you get responsible corroborating adults to come and be with you in a session, you'll frequently get a completely different answer. I've had them just shake their heads and say, there ain't no sex life in our family. And all he does is he uses his Oxy 30s, and he watches TV, he smokes cigarettes, he doesn't help around the house at all, he's not watching the kids, he hasn't looked for a job, or anything like that. And you can get a lot of information real quick. But these people will fight you as far as not wanting to have a significant other. They'll come up with all kinds of reasons why that adult child or spouse shouldn't come to that meeting. And I think that's extremely useful data to get. Go ahead.
Yeah, I would support with what Dr. Greenberg is saying. It's at this point, I think in my career, it's not been surprising the information that I'll get from the family member or significant other that accompanies the patient, and I've had that same experience where you ask the patient, look, we're really stressing functional improvement, what are you doing? And then you ask the patient, do you mind if I ask the person who's with you and who lives with you some questions? And you find out, well, you know, exactly that. You know, they're not doing much, they're just sitting on the couch, and you've got discordance. And that can be very helpful in your determination of whether you are going to continue the chronic opioid therapy or not. Going back to the pseudo-addiction versus the addiction, you know, it's an older terminology now, and in some ways can be controversial, but the premise of it was based on, well, if you're a pseudo-addict, you start to look like an addict, where you're asking for more medication that's being prescribed. And then the way to separate it out, as it was explained, is, you know, the pseudo-addict, their function will get better once their pain is adequately treated, whereas the addict continues to remain dysfunctional. To the question of what do you do for the chronic pain patient that's truly an addict, well, you need to treat the addiction. In my perspective, I don't know what I'm actually treating in the addict if the addiction hasn't been addressed. But in the process, you start then just exploring what are non-opioid therapies that can be explored for trying to address the pain, whether that's neuropathic analgesic medications, whether it's physical therapy, psychotherapy. Are there any interventional based therapies that can be done? But you know, you're dealing with somebody that's got a dual diagnosis of chronic pain and addiction, and you're not going to get a handle of the pain if the addiction isn't addressed.
I was going to echo the same comment that for those that have chronic pain and have an addiction, you're never going to get a handle on the chronic pain until the addiction is addressed first. And this is a difficult situation because you have which one came first, the chicken or the egg type of scenario. And for the patients who are in a great deal of denial about their own addiction, for the family members who want to keep that family together by keeping the addict using, it's going to be a very difficult decision for them to make to detox off of the narcotics, address the addiction first, and then begin implementing pain strategies that are non-narcotic dependent. But it is possible, but I would echo that the addiction must be addressed first.
Yeah, it's tough, especially if there's an enabling codependent or codependence within the family. It's extremely tough to be able to make progress. But one of the things we've used, and it works very well, is that we take advantage of the fact that most of these folks are going to have severe drug-induced cognitive impairment. Okay, they've never been tested for it, but they're going to have it. And so what we do is we'll give them like an Alzheimer's screening test. Of course, they may only be 39 years old. And we then document for them. We say, look, here's the deal, okay? Your short-term memory is shot, okay? And they'll admit that usually. They'll admit their short-term memory is shot. We'll say also your executive functioning, your ability to organize your day, shift from task to task, plan things, deal with new challenges is gone, okay? And often there'll be a spouse there that'll say, yeah, that's why he won't do or she won't do anything around the house or chores or work or pay bills without prompting. They forget everything. They lose their spatial memory. They lose their impulse control. All these things can be picked up on a really cheap screen, okay? And you use that and say, it is the drugs that you've been abusing that are killing your brain, okay? How about we get you off these drugs and see what kinds of improvements you're going to make, because you will get some of your brain power back. Now, when they're over 40 or 50, they don't get nearly as much back. It becomes more permanent. But for the younger addicts, it's a useful tool in intervening. And we say to them, you know what, you can take this test either by skipping your morning medicine dose and just take it with as little medicine as you can tolerate, and we can also take it again where you take your medicines, okay, and take the test, because it's not going to make any difference. These are chronic damages, and it's a useful tool. They're very cheap. You can get them. Some of them you get off the internet, although I'd recommend a microcog, which is a little more comprehensive than the typical Alzheimer's screen, but a typical Alzheimer's screen will work.
Introduce yourself.
Thank you, everybody. Great conference. I appreciate organizer for organizing this. I am a psychiatrist and addictionologist, and I have had difficulty all the time to prescribe anything that's addictive, and I have also stated in my website that I'd rather not do that, but sometimes it's inevitable. And I'm wondering if I could make a policy of my office that I cannot prescribe anything that is addictive. Would it be with the board? And refer the patients to other colleagues?
Yeah, I think in your own office, you certainly could do whatever you wanted to. Probably your business will go down dramatically. However, just as a follow-up to that question, you know, we've talked about you've got these addicted patients. We've got to get them off the opioids. What are the current best methods of detox available to these patients? What do you advocate?
Well, I can just give my opinion on this. I've detoxed people with many different agents, and whether it's for opioids or alcohol or anything, unfortunately, detox is the least important part of treating an addiction. You can take someone who's dying of alcohol withdrawal and NDTs and give them Valium, and within a few days they'll be feeling better and eating and drinking and stuff, but we don't get them treatment for their addiction and some kind of monitoring and follow-up, we're not going to have much success. I know that buprenorphine compounds are the rage right now, and buprenorphine compounds are certainly good for detox. We use them a lot in the indigent clinic. We have a 6-week detox, and then they're in a monitored aftercare and treatment program for a number of months after that. The issue I have with buprenorphine is kind of like my same issue that I have with self-declared chronic pain specialists, and that excludes our present company here. And then basically, it's just that there are people that study for the test and take the test, and they open up a drug treatment Suboxone clinic, and the patients come in. They don't get physicals, they don't get labs of any kind, and they don't get any kind of therapy, individual, group therapy, education, nothing. They're told to slap down their $500, five Ben Franklins, and they get 120 day. They get a 90-day supply of Suboxone. And they're told to come back, and when they come back, they're not peed, they're not examined, they get no therapy, and they do that. So that's a problem for 2 reasons. Number one, it doesn't help the suffering addict, in my opinion. And number two, the fact is that in Arizona, Suboxone's becoming a gateway drug because there's so much of it being prescribed out of clinics like I've just described. And what happens is that a lot of the addicts, when they get in trouble, like their dealer gets arrested or something like that, they'll come in for Suboxone, they get 120 tablets, they get a month's supply, okay? Their dealer gets out on bail 3 days later, so I say to these guys, well, what do you do with the extra Suboxone? Do you save it for a rainy day? And they say, oh no, I sell it to the peewees in the neighborhood because the kids think it's the cure for heroin addiction. It's gotta be safe. So, I don't think that the actual type of detoxification compound is the critical piece in treating addiction, and I could be wrong, but that's my bias.
Other comments?
I think the best way is to stop it. There's more and more evidence that opioids increase inflammation and cause more pain. There's hyperalgesia, and whether we have a good control on that, I'm not sure that the science is there. But I've had a number of patients where we have just come down in a stepwise fashion, and whether their cognition improves, whether their depression improves, whether they actually get better being off of these medicines, we find that we don't have to replace anything, and the patients do better. And in overseas, when they don't use them, they don't have those problems. And I think that's the first thing that you try and do. And then the second step is to get them into a Suboxone treatment, but make sure that the goal is to stop that treatment too. It's to get them off, and that's the real goal.
Ron, if I can just add a quick comment from an emergency medicine and inner city perspective. When we see patients withdrawing in the emergency department, one clinical caveat is that nobody ever chooses to withdraw on their own. So when we see patients that are withdrawing who are addicted to opiates, benzos, whatever the case, alcohol, whatever the case might be, it's because something else has caused them to withdraw. It's usually an illness, an injury, and so I think that I want you to take away from the discussion that although there's no perfect way to detox people and it's not a primary issue, that the addict that comes in that is withdrawing, it's not out of their own choice, and there's usually a medical reason behind that. And then, Ron, just to turn it back on you real quick, you know, you work at Cedars, and the rage for many years was the anesthesia detox for the opiate addicts. You want to comment on that at all?
Yes, I certainly can. I actually made a comment to Time Magazine about it. I said it was actually a good procedure in bad hands. And while it's a very interesting proposition, it had been advertised as sort of, you know, it's like washing your car once and it's clean for the rest of its life. And a lot of people have used this for that and their problems. I mean, it's not a non-innocuous procedure. In certain cases it can work, but I agree with what you said before. Basically, the aftercare is the critical. You get them detox, but it doesn't cure them. And the problem around the country has been that there are a lot of mills doing it and not doing it with good medical care. If done appropriately, it is just another modality that can be used. I had the privilege of learning how to do this at the San Rafael Institute in Milan, which is a 1,600-bed hospital owned by the Vatican. And having been there for 3 days, they said to me, well, now it's time for you to do one. I said, well, I don't have a license, not a problem. I don't have insurance, not a problem. I'm not on the staff of the hospital, not a problem. I said, why me? They said, you're from out of town. So the first person I ever detoxed was the consigliere for the Sicilian Mafia in Milan. I'm going to take one question here, and then I'm going to come back to the gentleman on this side because I want to ask the pharmacist a couple questions. Go ahead, ask your question. Just tell us who you are.
Yeah, my name is Robert Kutzner. I'm a pain specialist, anesthesia background, intensive care, and also interventional, old guy. So now I'm just got a little clinic, pain clinic, and work with multidisciplinary approach. Anyway, my practice, yes, I see the addicts come and go, but you know, there's ways to address that. One is cures, which is a great program, guys. Maybe you run a little bit behind, 1 month, 2 months. Sometime you'll get, take care of that. But specifically, when I am dealing with an addicted patient, somebody that's drug seeking or they have a lot of drugs, I don't deny that they might have pain. Obviously, addicts can have pain too. I take advantage of the opportunity to treat them. I got them now. Okay? And we try to do at that time cures and pain agreements, etc. One of the things I do is old school, been around forever. I'd like someone here to comment on it because I don't see it in practice too much. There's a few people that do it mostly at the university level, but that's a blind pain cocktail. It's very hard to snort up cherry syrup or shoot it up, etc. And it works very well. It's been around since Egyptian times. Would you comment on that, please?
I think blind pain cocktail is a great way to supplement a detox. But one of the things that we learn is that detox and treating an addict is not it's not a monodisciplinary field. You need help. You can't do it all on your own, especially those of us of anesthesia background.
Yeah, let me interrupt for just a second because I have a Suboxone license and all that stuff. I don't detox patients. I got a clinic, and I'm treating pain. So it's not a detox issue. It's an issue of controlling diversion.
Well, it's also an issue of opiate reduction. I don't think it's really possible. It's very difficult to assess a patient's pain when they're on large doses of opiates, especially if they're walking in the door on large doses of opiates. You have no idea what their baseline is. And it may be that they're hyperalgesic. It may be that the opiates have accelerated their complaints of pain. And so you really do need to do some kind of opiate reduction. And whether you want to call it detox or opiate reduction really doesn't matter. And a blind pain cocktail is a really good way of doing that if you've got a cooperative pharmacy and a cooperative patient, and you've got the whole thing set up.
Okay, so why, you pharmacists and you physicians, why aren't we turning to that for these minority of cases?
I don't know what that is.
A blind pain cocktail, you come to me and you're taking, 100 milligrams of morphine a day, equivalents of hydrocodone. I give you 60 milligrams in morphine or some narcotic in cherry syrup. You get your little flask, lasts for 2 weeks. I probably put hydroxyzine in it and acetaminophen, something like that. You agree that you will not know what's in there. If you want to know, just ask me. I'll tell you, or ask the pharmacy, I'll tell you. But then, boom, you're done. If you do that, then I take every 2 weeks and I cut back the narcotics. I have one patient now, I've had many in the past, will end up on cherry syrup, and I end up having to tell them, hey, we're doing good now, you can just get off the stuff.
Okay.
So you're right, it works very good. I'm just flabbergasted that with all the people that are dying and stuff, all these things going on, I know that Dr. Mackey at Stanford does it, I know a lot of people who do it. Why aren't we doing it? Why isn't it being promoted?
Thank you. I'd like to ask the pharmacist, once the determination is made that a patient before you may be addicted, what do you do?
Yeah, so if a patient presents to you and you determine that they're probably addicted, you've probably made a contact to their physician to kind of get confirmation on that. I think the idea is really to kind of look out and get some help for them. You probably, if this is a patient that regularly coming to you, you will have a relationship with them. You have that discussion with them that you are concerned with their health. You are looking out for the patient's best good. You may want to refer them back to their physician, maybe refer them to a pain specialist to figure out what's the best option for them. The pharmacist definitely has a responsibility not to fill that prescription for a patient if you really know that they're addicted, because you need to prevent any harm to that patient from happening.
I just wanted to add a little bit about that. I always look at the issue between dependence and addiction, and we have to make sure that the addiction piece of it is that there's the psychosocial behavioral issues, the functional issues, the diversion, and I think that's where the pharmacy has to come in and address that. We have, had patients there, and we go and talk to the patient, because a lot of times it's really difficult to get a hold of the physician, and ultimately we can say, I'm not going to fill it, but I like to follow the patient-centered model, and I talk to them and tell them, I said, I have concerns about what you're getting, where you're getting them, the doses, and I kind of lay out what my concerns are as a pharmacist, because again, we have this much information. But I do think it needs to be addressed by the pharmacy, and we can tell them at that point that I am not going to fill it, or I need to get a hold of your physician before I can fill this. And nobody really dies from withdrawal, at least from opioids, and it is uncomfortable. But I will it's not an emergency in my mind. I need to get a lot more information as a pharmacist. But we're definitely at a very limited space there.
At what point should the pharmacist pull a cures report?
Well, I promote that we should be pulling cures reports a lot more, and actually in the cures presentation, I think it should almost be proactive and prospective. And a lot of times the way we get information when we're filling prescriptions is we get feedback from the third-party coverage, the insurance company, and they just got this filled yesterday or 2 days ago at such and such. Unfortunately, Cures isn't quite that quick. I think most of the data is pretty updated, but that depends on who's submitting it. But I think we should talk about some guidelines and when a pharmacist should pull a Cures report. I mean, I think that's the reason for having this meeting, and I would like to have a lot more input on it, but I think we should pull reports a lot more than we're doing. When you have a question and a gut feeling, that's a really good indication that you should probably look at a Cures report.
Caesar?
This actually dovetails right into that in the sense that when Cures first came out and I started logging in, I tried it to see how good my hunches were going to be about whether somebody was an opiate addict or misabusing prescription medication. So I started, once I see the chief complaint and some basic data, I can kind of tell who's going to be there shopping for narcotics versus not. And I started running the Cures report. And lo and behold, frankly, the number of hits on Cures was quite low. And I work mostly in the inner city, so these patients are not filling their prescriptions. When they're given a prescription from the ER, they're coming in, getting the IV antibiotics or IV opioids or benzodiazepines, and then being sent home, but they never fill a prescription. So I think that Cures is a good resource, but it's not the end-all be-all by any means. And I think there are some shortcomings that we really do need to identify to make that database a little bit more robust.
One comment to dovetail on that, in terms of not being able to see what's administered in the emergency department, if you've got patients that are also being seen in the VA healthcare system and are getting their medications from the VA pharmacy, that will not show up on the prescription drug monitoring program. And then the other thing is it doesn't cross state boundaries. So there are inherent limitations. As long as you understand it, then you can make a better assessment of how to care for the patient within the limitations of what that data can provide. And also, it's only as up to date as the individual who's inputting the information. So as physicians, we're relying on the pharmacist to update that system. And I've had a number of cases that I'll look in the prescription drug monitoring program, and the patient tells me they're on a medication and I don't see it on the report. Well, I'll ask them, I'll give them the benefit of the doubt, and I'll ask them, where do you get it filled, and can I contact that pharmacy? And so I'll contact the pharmacy to then verify, was it dispensed or was it not? And some of the time it's actually been dispensed, but it just hasn't made its way to being updated and logged in. So you have to be careful in how you interpret the information. I'd encourage everybody to sign up for it. It's free, and use it. We recommend using it on every patient that's going to be prescribed opioids.
Actually, I think they were going to collect some applications today. Is that right, Mike? So you have an opportunity here to put in an application.
Is your notary present?
I'm going to go over to this. Gentlemen have been standing patiently. Take a couple of questions there.
Thank you. My name is Bruce Barnett. I'm a physician. I'm also an attorney. I work in corrections. I see inmates in the prison regularly, and I advise physicians about their problems dealing with inmates. And the problems they're having is making them crazy. And by the way, as a state employee, I've been trained to say that everything out of my mouth is from my own brain, my own opinion, has nothing to do with the state. No one put me up to this question, so please forgive me. And it's my question. But my colleagues really want to know from day to day how we can stem the tide of complaints that come from inmates in jails and prisons who keep accusing the doctors of malpractice in letters to the medical board, to you and your colleagues, Dr. Winder. Also, even in lawsuits before state and federal agencies, even sometimes medical malpractice lawsuits. What happens is the physician will not renew the inmate's prescription for opiates that they obtained in the past, either when they were out of prison or in prison, from more naive doctors who didn't recognize the addiction or the misuse. And they've been intimidating providers to get all these pain medications for alleged pain over a period of years. Finally, the physicians wise up, stop them, because in fact there is no evidence of significant anatomic or physiologic dysfunction to validate the pain complaint, what was talked about today. No objective evidence. No one else sees them in pain. They play baseball, so forth. How do we stop this stem of complaints to the medical board, and when will the medical boards recognize the source of these complaints? Thank you.
Thank you. Introduce yourself.
Hi, I'm Norman Reynolds. I'm a physician in practice in San Jose, and I do fitness for duty evaluations. I served as vice chair of the Federation of State Medical Board developing their latest policy on physician impairment. My question to you all is there some process by which boards or regulatory agencies review third-party payer policies that work against physicians properly evaluating and monitoring patients in terms of lab, proper workup, review of records, and reimbursement for the amount of time devoted to such cases?
That's a really good question. And by the way, Dr. Reynolds does the best fitness for duty evaluations that I've ever seen. If you've got a tough employee or whatever, boy, I've been very impressed with what he does, and they're meticulous and thorough. I think it's a sad state of affairs that the insurance industry can and does approve all kinds of treatments and medications and diagnostics that are unproven. And yet, when it comes to good old-fashioned going through the medical record, making phone calls, checking things out, talking to previous treating physicians and things like that, they don't reimburse that. You really get to learn something about a system when you see what it values and what it rewards. And I believe that our current system doesn't value good outcomes. It doesn't value good medicine. We're just rolling on like a locomotive that's running out of track.
I guess the question is there any mechanism for being able to do that? Or are we really just dealing with separate entities that aren't talking to each other? I could ask the question, I don't know the answer. Any other comments on that question?
The grim truth is that the system promotes escalation of drug, but the system does not promote de-escalation of drug at all. So once you get a patient dosed up, how do you get them dosed down again? That's the big problem.
My name is Joshua Friedman. I'm a psychiatrist on the clinical faculty at UCLA, and I supervise in the mood disorders clinic there. My question is, it seems like previously, 10 years ago, there was a simplistic interpretation of opiates as being completely safe and simply underused. And I think we've had to date in this conference a very good call to arms to get religion about the dangers of overuse. But I think really what we need to do is be getting a sense of the distinction between proper use and improper use of opiates and how we do that. And it's been hard to glean from the data to date. And I'd like to get a sense if any of you have a sense of, is this a problem that's spread evenly through all patients who are getting opiates? Or is it at 5% or 2% that are abusing it and 98% are getting it appropriately and it's working appropriately?
That one.
Let me take a crack at it. I think that the difference that we probably want to talk about is in the way that the patient utilizes the resource, because I would see the opiate medication as a resource to alleviate pain. Is that person have a single physician? Are they going to a single pharmacy? Are they compliant with the treatment? Are they pursuing other modalities to control pain? Do they have a care plan? Do they have a pain contract if they're at risk for addiction or have inappropriate use in the past? And those patients are showing me that they are more advanced in their management of the disease, that they have control over their pain, and that they are working with their doctor and other healthcare providers as a team in order to address their pain. Those patients, I don't think anybody here would have a question about treating them with narcotics and addressing their pain adequately. I think that the other group that we're talking about, and I think the group from which the escalation of the inappropriate prescriptions is coming from, are folks that do meet a criteria for an addiction, or the old term, perhaps even a pseudo-addiction, of questionable pain source, questionable use of physicians, multiple pharmacies, inappropriate prescriptions, no alternative modalities of pain management. And so I think that that is probably, at the end of the day, when we have to synthesize how do we focus our efforts, those are the individuals, and I wouldn't necessarily call them patients, but those are the individuals that appear to be misabusing the system, misabusing the drug, and who probably the largest focus needs to be on. And I think that I don't necessarily want to say that they don't have an addiction or that they don't have a chronic pain syndrome, but that their behavior is leading us to question whether or not this is really more of an addictive behavior or criminal behavior rather than a traditional medical pain management concern.
I'm going to mention, I know Darlene mentioned Scott Fishman's book, Responsible Opioid Prescribing, and the kind of the different layers associated with making the decision to trial opioids is probably the very first point of contact. The primary care doctor that's seeing a patient come in front of them, they think they have legitimate pain complaints, want to trial opioids, want to make that decision, have to have some kind of a plan or protocol to make that decision process. Risk stratification is what I think is probably the best approach, and how to really take that look. There's different articles out there. Doug Gourlay created a universal precautions approach, suggesting that there's this addictive potential in society, potentially at a certain percentage. We should, if we're going to decide to prescribe these opioids as that particular agent, that we should take this into consideration. Patients that are presented that they're going to be prescribed this medication, for one, it should be presented as a trial, as a brief trial. They're not going to be continued on the medication necessarily. Functional metrics have to be chosen to determine if the trial is rational to continue. Those functional metrics, different pain doctors have different ways of doing it. Some doctors will have pedometers that they'll pass out that may be too difficult to demonstrate some functional metrics. Having family meetings, maybe describing what's going on in the family, what their functional capabilities are, holding a job, staying in school. All that data is collected and documented. Then you'll notice that there's other considerations, comorbid depression and untreated psychiatric conditions that might obscure the trial. Maybe those patients aren't necessarily good candidates for chronic opioid therapy, or even that opioid trial that you're employing to begin with. And lastly, symptomatology of abuse. So those, I think, previously, those factors weren't discerned, and suggesting that a trial of this therapy wasn't appropriate for those patients. And then once that data is collected, ongoing visits, collecting that important information, that prospective potential for addiction is ever present. So it's keeping that ledger at least up to date. I would say it's a change in the standard of practice, and with physicians, and making that the standard, and that standard is what then we'd be accountable for.
One thing that looking at the literature kind of retrospectively, if you look at the original studies that the FDA used to approve these medications, very few of those patients are still on opioids. And the selection process for those patients were single problems, single pain complaints, and no psychiatric or other medical conditions. And they all are stopped these medications due to lack of efficacy and to a lack or side effects from those medications. So if the best patients can't stay on them, who do we have on them now? And so that's always kind of a scary thing for me, knowing how many prescriptions that I've written. And kind of sarcastically, if the patient's still on it, that means you've got a problem. But there are patients that are still in pain, and unfortunately, though, we're starting to find that these are really causing more and more pain.
Any other comments? The back on the left.
My name is Dieter Steinmetz. I'm a pharmacist, and I'd like to address a couple of the questions that were posed earlier. The blind pain cocktail, from a compounding perspective, we have to list every ingredient in a compound, which means it wouldn't be blind. We'd have to actually list everything on that formulation. The second question I wanted to address was the filling a prescription. If, as a pharmacist, we know that the patient is addicted, clearly that's not for a legitimate medical purpose, which means as a pharmacy and a pharmacist, we would not be able to fill that prescription. So if we become aware that a patient is addicted, we have to refuse to fill the prescription, which I think obviously creates a big problem from a doctor's perspective as to how is this patient going to be treated. And then secondly, I would also like to say that Cures has been a wonderful program for pharmacy especially. I've enrolled, I look up almost every patient, maybe not every time they fill a prescription, but very frequently, and it does give us at least another tool to try and ensure that that patient is being treated by one doctor, prescriptions filled by one pharmacy, and is being done appropriately. I would like to go a step further and ask some questions as far as what are the clinical practice guidelines? Is there a stepwise approach in treating patients if they're starting out with, say, 30 tablets and then going to 90, 120 more powerful narcotics? Is there a stepwise approach that I as a pharmacist could say to the doctor, how do we know that this patient is truly needing those medications? What testing has been done? What referrals have been done? You know, is there a guideline so that we can take patients that truly need pain medications and make sure that they are treated appropriately? Thank you.
Good question. Does somebody like to respond to that?
At least from I'll give you two perspectives on that. One is from the medical board pain management guidelines. They are out there. There was a big emphasis on narcotic use in the past, but the guidelines are not specific regarding dosages and the like. During the development of those guidelines, there was a lot of testimony from patients who were concerned that if dosages were, or number of pills or milligrams and the like were included, that they felt that they weren't going to be treated appropriately. And these were folks with some legitimate pain concerns. But I think that is up for debate and rediscussion. I think those pain management guidelines probably need to be updated, as they're about 10 years old now. From the perspective of the American College of Emergency Physicians, we do not have pain management guidelines, and that is one area that I'm going to emphasize that our college are working on, because physicians do need some guidance, and if we as a college are able to take some proactive effort, I think it'll be better for the entire practice as a whole. I'm not sure regarding internal medicine, anesthesia, and some of the other specialties.
There are different sets of guidelines. I think it's trying to find that cohesion is what you're looking for, probably all of us. The American Association of Pain Medicine has a set of guidelines. There are articles last article just came out in Pain Physician. Machakanti has a group of potential guidelines to guide physicians prescribing pain medications, opioids in particular. So I think it's trying to create a cohesive picture, and I think that's still what's lacking. I think the Federation of State Medical Board, the book Responsible Opioid Prescribing, does have a decent approach to that, and I think it does give you an indication as to how to make that decision process. But as far as formal guidelines, that's exactly it. I mean, and then speaking on guidelines, guidelines, just like in anesthesia, for example, we have this Anesthesia Society of Regional Anesthesia for what's required guidelines for anticoagulation therapy and when you can actually do neuraxial procedures. Their guidelines are not always exactly hard and fast rules. So it's just something to keep in mind as we kind of add to the body of literature.
But I think I don't know the answer to that gentleman's question who's a pharmacist, because I think it's a good one. How does a pharmacist know? I think his question was, how does a pharmacist know that, well, last month the patient was getting 30 tablets of the opioid. Now patient's coming back a month later and 60, and a month after that on 90. How does a pharmacist gain access to that information? Because the pharmacists are not interlinked to our electronic medical records. I'd ask our pharmacy colleague, how can a pharmacist help us as clinicians, or at least help society with this problem?
So I guess one of the struggles we have is a lot of us are not connected with an electronic medical record and have access to that type of information with all the regulations and the rules behind HIPAA and so forth. But I think a pharmacist, I think, should try and have a discussion with their physician that when they do get prescriptions like that, where they're noticing that the dosages have been escalating, they're noticing any changes in their therapy, that they do discuss that and essentially confirm and validate that that is appropriate therapy with the physician when they prescribe that medication. I know when you're working in a health system and you have sort of a closed system, I think that access is a little bit easier and a little bit more available for pharmacists to get that type of information, whether you're in the VA or Kaiser and so forth. But I think outside of that, it's going to take a lot of proactive care from the pharmacist to make sure they reach out and get contact with that physician to make sure it's done in good faith.
And just one quick question. Do you guys, as pharmacists, do you have to get consent from the patient to have that discussion?
No.
With another physician?
I think, just the one thing is, if the doses are being escalated quickly, that's a bad sign, and that's a reason why an opioid trial will fail, or a reason why the medicine shouldn't be continued, or you should be thinking of other things. Opioids are the only drugs that we double when they don't work, and it's so.
And to echo that, I think that it also shows that tolerance is being built, which is obviously one of the different components that we look to determine whether there's some dependence involved with this. So I think it's a great red flag, and good pharmacists have always called to let us know of those issues. I realize that sometimes we're not the most receptive ears as physicians at the other end of the phone, but sometimes you're acting on the patient's best behalf, and it is appreciated.
Okay, my name is Jeff Harris. I work for Kaiser, and one of the things I do is evidence-based medicine methodology. And I'd like to ask if the panel could comment on the state of research on the effectiveness of opioids for chronic non-cancer pain in randomized controlled trials and other studies which are not involved in conflict of interest to find out if in fact this is effective. And a follow-on question, all of the guidelines we've reviewed talk about using these only for appropriately selected patients, but absolutely none of them define that. So I'd like to ask about that as well.
Very good. Let's start.
I would just say that what I've found I've had to do as far as to get studies that appear to be well made, well designed and well executed without bias is to look at the European and British literature. They're far more likely to be doing quality studies over long terms of time with the proper number of participants than what we produce, and they're far less likely to have the name of McNeil or Sandoz or ortho or whatever on the bottom of the study. And I think that unfortunately the European literature is probably the best. Finland is very good.
I would mention that there is Nobel did a Cochrane database review on this, and you can look that up. It was in 2010. There's, I believe, another one in 2012. One of us was we were talking about this. Which the evidence actually, and this has been mentioned already, for chronic opioid therapy is pretty glim, as an appropriate therapy for pain anyway. Even studies existing for chronic opioid therapy lasting longer than 3 months in the fashion that you're describing just don't necessarily, to my knowledge, exist. And as far as evidence for it being held up as an appropriate, sustainable pain therapy are fair at best. But I think a Cochrane database review is maybe something that you could start with, is some of the evidence-based medicine.
Commenting on the appropriate patient, that's a real difficult. Younger age is not a good. The patients that have high-risk incidents or problems with medications, single disease processes are better. And something that is very objective at finding somebody that's had 8 back surgeries versus somebody who has Mediterranean fever would be the examples of that.
Yeah, I think it is a good question of who is the appropriate candidate. It comes down to clinical judgment based on your risk stratification. As many of us have said, Dr. Bolson has said, you know, it's somebody that's going to be in a high-risk group it doesn't mean that it's an absolute contraindication. It just means that there's going to be more pharmacovigilance that's required. But somebody that's young, history of sexual abuse, history of prior or active substance abuse, those are probably not going to be the best candidates to initiate a trial of chronic opioid therapy. Or if there's question about it, then refer to a pain specialist if one is available. That's a high risk candidate. And in terms of the evidence question, I'm not aware of any that's not funded by the pharmaceutical industry that's looking at the efficacy for long-term chronic non-malignant pain management. But doesn't mean it's not there. I'm just not aware of one.
I'm going to take the prerogative of the moderator and ask a question, and then I'll get to everybody, I promise you. And I really wanted to mention the surgical patient, which we really haven't touched on. What do you recommend preoperatively for a patient with substance abuse disorder who's scheduled for very painful surgery, such as a repeat spinal fusion? I'm going to ask Howard to start off with that. We're the largest spine institute in the United States. We did double the Cleveland Clinic last year, which was number 2. We do 35% of all spine surgeries done in the state of California. And I don't think any of these patients aren't on opioids before they come in. Howard?
First shoot at the spine surgeons.
That's not a bad idea.
Then shoot the people who are prescribing for them. It's a very, very big problem. Outcomes of painful surgery are difficult at best in the ideal patient. And as an anesthesiologist, we know we're not going to operate on people who have fresh MIs or fresh CVAs who are medically unstable in one way or another. And patients who are maintained on high doses of opiates are just as unstable and unsuitable for surgery as patients with other ongoing medical problems. Patients who are already tolerant to opiates and hyperalgesic going into surgery are going to have miserable postoperative outcomes. They're going to have prolonged lengths of stay. They're going to have prolonged ICU stays just to try to achieve some pain control, and it costs the system an enormous amount of money. And at the end of the day, they still have their pain after their surgery, and they're still on high doses of opiates. So what have we gained? We tried a little experiment in trying to do opiate reduction prior to surgery in cooperative patients. And try to get them down to as low as possible or to 0 and give them a chance to recalibrate. And those patients tended to have similar outcomes then to patients who are opiate naive in the lengths of stay that they needed to have in order to be able to be within the guidelines that are being established now. And their outcomes tended to be a little better. It would be nice if we could do this on a wholesale basis with all patients going in for very painful surgery to do an opiate reduction with them, give them a little bit of time. And some of them may actually not need surgery once they get off of their opiates because their back pain gets better.
Other comments, pain docs?
I hope I didn't insult any spine surgeons.
Just as a corollary, it's kind of more of a question, but a follow-up question for the pain docs and the people here is working in an acute hospital. We often get a trauma. Maybe it's not a spine patient, but somebody who has trauma. They have acute pain, and they have a history of addiction and have been on high-dose opioids or opioids of probably undetermined amounts. How do you treat them? And I know that I at least want to address the legal parts of it, that it's legal to treat the pain in a patient who has an abuse history in that situation, but it's an acute situation. But what do you do?
Let me comment on that one from both as an emergency physician and as well as having been on the pain management task force. In 2004, when we looked at chronic pain management, one of the caveats that I made sure that we addressed, it used to be that the Medical Practice Act would say that narcotics addicts could never receive narcotic pain medications. And we actually changed that in 2004 to show that if it was an acute pain situation that required narcotics for treatment, that we could prescribe them without fear of facing the DEA or the board. And our examples in the pain management guidelines would be somebody that comes in that's an addict that has an appendicitis. That's a painful procedure, is going to require surgery. There's a role for some short-term opiate treatment. But at the same time, we certainly can't put that person on a methadone maintenance while they're in the hospital. There are other restrictions in place. I think that the trauma patient is very much the same. They tend to be polysubstance drug abusers, so I don't think it's just the opiate. It's going to be the alcohol, it's going to be the cocaine, it's going to be everything else that they're withdrawing from. And it certainly creates a difficult management in the postoperative period if they do get surgery to try to manage all the withdrawal while also trying to manage pain and their vital signs, their basic vital signs, and their recovery. So it is a challenge. I think there is a role for them because you don't have a choice. In many cases, they're not going to handle the stress of the detox on top of the physical stress of the trauma. And the part that I always mention as a caution for folks that are treating trauma patients, I've seen this happen before, they're on an alcohol drip, they're on a benzodiazepine drip, and it's time to move them from the ICU to the floor, and all they did was just turn off the drip. Now that patient is withdrawing on the floor, and so we have to manage the disease of addiction for that patient, both in the ICU and on the floor, and when they get discharged home. Otherwise, we've done nothing for that patient. And usually the number one reason why they ended up in the traumatic situation was the substance abuse. So it's the underlying reason that we should be treating along with their injuries.
Yeah, I think that those withdrawals, each one of those drug withdrawals becomes difficult, and we have very few options to treat other than the opioids, the benzodiazepines, to work with the alcohol, and that becomes difficult with that. But I think ethically, when they have acute pain, it's not a time to detox their opioids, and that you do have to treat them. They're going to discharge themselves from the hospital as quickly as possible so they can get back to their pain physicians. But those are very difficult, and trying to plan those surgeries and get some comments from their treating physicians before it goes in is important.
Ron, if you'll allow me a little levity here. I trained at LA County USC Medical Center, and for anybody from Southern California, you remember the big behemoth concrete building that we were in. Appropriately across the street from the largest trauma center in the country was a liquor store, appropriately named Liquor. And it was so good, they named it twice. There was a routine that, doctors rounded probably about 6, 7, 8 o'clock in the morning. By 9 a.m., you saw a train of IV poles with banana bags walking down the sidewalk down State Street to Liquor to buy their alcohol to keep from withdrawing, because we weren't doing a good job of managing their withdrawal while in the hospital. So that was a reminder that we probably need to do a better management of all our inpatient folks with addictions that require medical care.
Okay, you've been waiting patiently. Introduce yourself.
My name is Todd Stolp. I'm health officer for Tuolumne County. I had one observation and then a question for the panel. The observation had to do with recognizing the importance of primary care to this whole issue. Following up on Dr. Aristeguieta's question this morning, how many physicians are primary care physicians? Family practice, internal medicine? Okay, not quite as many as those that raised their hand this morning, but I do think the special problems facing primary care, including the lack of insurance coverage for recovery services, is a very important part of this component, especially for safety net services. Medicaid patients in our county 50% of those who died of overdose deaths were on safety net services, safety net insurance services, and had sought recovery services, but they were not available on those safety net programs, Medicaid. So I do think that Dr. Aristogita's point this morning about having primary caregivers spend time in the emergency room is a good one, but I also think it would be helpful to have emergency room department folks spend time in primary care practices to recognize those special challenges and opportunities that are faced. My question is, in December, the Let's Get Healthy California Task Force, put together by the governor, created 39 indicators of community health. Of those 39, 2 related to substance abuse, and both of those had to do with tobacco consumption. What would the panel decide would be a good indicator of community health relating to this problem of prescription drug abuse?
Start with, go ahead.
I think that the problem is deeper here, and the medical profession has some responsibility. When we are trained in medical schools and in residence, they don't teach us about addiction. Not only that, they don't teach us a prescription practice. And this is something that is, the medical schools of today still are being run from the 1800s. That means there is no change. And if we're going to seek a solution in this silent epidemic problem, we're going to need to go to the medical schools and the resident trainings to try to teach us. Now, the doctors that were in practice already, many of us, including myself until recently, I couldn't recognize a patient who was addicted. Now I have, as an obstetrician and gynecologist, I have a little bit more knowledge. But the problem is deeper, and we should try to seek that type of solution. In the primary doctors, who they see these patients, but they were not trained how to identify this problem.
Yeah, the parameters I'd look would be for reduction in substance abuse-related trauma admissions of all kinds. I'd look for reductions in babies that were born to mothers who were using crack or using opioids and addicted babies that need ICU time. I would also look at reduction in incarceration rates in that particular community. And there's a whole bunch of other stuff that could be looked for as far as STDs and things like that go with addiction. But I'll put one plug in for this. I think the answer will come largely with the formation of not family homes, of medical home, a type of medical home concept, and not necessarily what the government is saying right now, but some type of medical home that has family practice care. It has someone who knows something about social work. It has someone who knows something about mental health. That has a good psychiatrist that they can be backed up by, and then also that has some type of addiction type treatment, and probably parenting classes too. I think that those kinds of things within a medical home would wind up being cheaper than what we're doing now, and probably more effective. I can't prove that, but that's my gut from working in this field for a little while.
I'd love to look at milligrams per zip code. and just do it that way.
Yep.
Any other comments? All right, I'm going to call on you in the order in which I saw people. You're next, and then we're back to the back.
I'm Barbara Showalter, a family doctor in Merced, California, which is out in the Central Valley with about 80,000 people. One brief comment first. In the pain contract that I do, I put in that they sign that I can contact family members and friends about the effects of their pain medication. So then it's up front and it's already been consented to. My comment really is that along the guy from Tuolumne County and Merced County. We don't have a pain center. We don't have a pain specialist. We have a couple of general neurologists who also work with pain. We have two doctors who work in one clinic who will do epidural injections. We don't have any psychiatrists or psychologists that are specifically trained or work with people with pain, and even those that we do have in mental health are not available unless somebody is actually suicidal, homicidal, or hallucinating. There's very little resource. Many of the patients that I treat do not have transportation, do not have money. The thing of one pharmacy, even when I write a prescription a week beforehand and personally call to the pharmacy, which I don't with most of them, if the pharmacy manager happens to be away for a week, they're not going to have the medicine ordered, even in people who have been getting it there for more than a year every month. So the one pharmacy, that's not an indicator for me in Merced. And so there's a lot of, this is all really nice perhaps in big cities and with people who have insurance, but it doesn't, many of the indicators and many of the things we would hope to be able to do don't work out with certain types of patients and in certain areas of the country or state.
The back of the room.
I'm Mark Holtzman. I'm co-director of the Inpatient Pain Service at UC Davis Medical Center. I have two questions, one for the pharmacists and one for the physicians. So the one for the pharmacists goes back to the question about what do you do with a prescription that you're presented for a patient with addiction. So, number one, how do you document that addiction? What are you looking for as a pharmacist? And number two, do you then, as part of your patient-centered care, refer them for treatment to like an addiction specialist? And what do you do if you're in an underserved area? The question for the physicians is, with regard to the patient that's a chronic pain patient on chronic opioid therapy coming in for an elective spine surgery, do you know of any evidence-based medicine that suggests reducing the opioid dose or stopping the opioids prior to surgery improves the outcome? Thank you.
Start with the pharmacist.
So as far as the pharmacist role in that, I think it's still rather limited. It's still going to have to go back to the physician. But if you're filling a prescription that you believe is legitimate and necessary, I would say, and we could probably check that with the board too if we have some board representatives who wanted to speak, but that you would need to document what you're doing and why you're doing it. And that would probably be the best case. But you're really going to need to follow up with the physician, because the physician's the one that's going to need to make the decision about the treatment plan and getting them into a program. We can make the recommendation, but I mean, we're dealing with the same thing as scarce resources, and the people who need it the most are not funded or underfunded. And even though the county says they'll take them, they're not open when we need them to take them. And, there's a lot of different issues to deal with there, and we're usually getting them from the emergency room. They're trying to fill some prescriptions to get them through a time period till they can get them into a program. But we are talking about some different solutions, at least at UC San Diego, about starting a bridge clinic that's for pharmacy and for dual diagnosis patients. We got together a whole task force because the pharmacy refused to fill a prescription. And it caused a big brouhaha there because we said, this is illegal, we can't really do it. This is a dual diagnosis patient who's drug seeking and came in saying he was suicidal. I mean, it was a multi-problem problem. But we ended up saying we can't fill these prescriptions. They ended up getting him supposedly into a program, but they wanted to get more prescriptions. It was a third fill in a day that they were asking us to do, and they kept changing from benzos to opioids, because he was asking for them. And we actually ended up saying, no, we can't fill these because we feel he's going to take the prescriptions and he won't go to the program and he won't follow up. It was a really hard decision, and it took like hours of several people's work, and we were talking to the doctors up to the director of the emergency room, who was not happy with us at all that we weren't filling these prescriptions. But I don't really have a great answer for that one, because I think the problem is we don't have the resources to refer these people who really need treatment.
the second part of the question? Do you want to repeat the second part of the question?
Yeah, the second part of the question was for the physicians, if you have a patient that's on chronic opioid therapy, they have chronic pain, they're coming in for an elective spine procedure, is there any evidence-based medicine, any evidence to suggest that reducing the opioid dose prior to that procedure or stopping the opioids is going to improve the outcome?
So that's hard to find in the literature. The project that we did was a QI project that looked at data over many years in terms of comparing lengths of stay between non-opiate users and opiate users in major joint replacement and lumbar fusion surgery. And the data that we were able to cull from thousands of surgical patients was about a 4-day length of stay difference in patients who were not on opiates and patients who were on opiates. We then did a very, very small number of patients, who, of course, who were cooperative in reducing their drugs prior to surgery and in many cases getting them off. And their lengths of stay returned to what we would have expected for patients who were not opiate seeking, or were not opiate users. It's a big jump to go from there to say that, yes, definitely patients should be detoxed, but there just isn't enough data to say that there is this huge outcome difference. There is some data from the work comp system in the state of Washington looking at postoperative morbidity in lumbar surgery, which does seem fairly conclusive that patients, that the one big difference in postoperative morbidity was opiate use, and that there was a significant increase in morbidity postoperatively in opiate users versus non-opiate users.
Ron, I wanted to comment just briefly. As you were pointing out, sometimes when we get a patient that is seeking narcotics, benzodiazepines, barbiturates, whatever the case might be in the emergency department, those patients are very difficult and very time consuming. And I want to make sure that we talk a little bit about that, because the same problems you're facing in the pharmacy with the difficult patient that you've identified as having an addiction who does not have a medical necessity for that prescription, it's the same problem that we're facing in the emergency department. And I have to tell you, I work in a very busy inner city hospital where I'm seeing in the neighborhood of 18 to 24 patients in an 8-hour visit, many of them very ill and very serious. Our admit rate is somewhere in the close to 40%, so they're very sick patients. And I get one addict that comes in looking for, you know, a simple refill for their Vicodin. The pressure is on the physician to just fill the medication and get them out of there rather than address the underlying issue. So I want to reinforce that we need to do a little bit better job in the way that we communicate all this information to help us make that clinical decision that the individual does not need an opioid pain prescription or a benzo or a barbiturate, that what they need is pain management, what they need is referral back to primary care and those type of things. And so as we develop plans from this conference to move forward, I'd like us to start working on ideas of how do we share this information amongst the pharmacists, the clinicians, law enforcement, the board, and so forth, so that we can be all on the same page much more quickly than we do right now.
Any other comments?
This is a pretty fantastic conference, I have to say. I'm Dr. Forster from San Diego. I've heard today and yesterday several times the difficult duties of our pharmacology colleagues, the pharmacists, to decide whether a prescription is appropriate or not appropriate. The question is, of course, that puts, I think, every physician is writing its prescription with the best wisdom and conscience and evaluation of the patient. So the question is now, if I could learn a little bit more about the criteria under which a pharmacist executes his obligation to check the prescription and determine if it's appropriate or not.
Pharmacist?
I think when we go through school, in pharmacy school, trying to determine the pharmacology of all these different agents, we get back to, are these medications appropriate for your situation? And as you know, with a lot of opioids, there's extensive range in terms of what these patients are taking and the doses they're taking. It's very difficult to determine that. And I think, especially when a patient presents the first time to your pharmacy, you don't have a history on that patient, it's very difficult to determine whether that is appropriate for the patient or not. A lot of times the pharmacist will trust the physician that, they're writing it in good faith, that it's a correct prescription. But if the pharmacist gets some indicators where they may not think that's the case, they will check cures, or they will make sure they contact the physician if there's any doubt that there's an issue with the prescription. It's always easier to just fill it for the pharmacist because they don't have to deal with all that extra stuff. But I think it's a real responsibility that we do take that extra step, especially making sure that we are managing that. We are the last line of sort of that medication process. So we need to make sure we do our due diligence to make sure it's correct prescription for that patient.
And again, I think we're promoting that we use the same guidelines for prescribing and use of these medications that physicians do. I think that the pharmacists really tend to be, pharmacists can easily fill it, like you said, or they can refuse to fill everything. And we don't want either. We want them to make those clinical judgments. We want them to communicate more. But I don't want to dissuade pharmacists from filling all prescriptions. And pharmacists tend to be sort of black and white as far as my, kind of connections with pharmacists, is they want this answer and they want me to tell them how many milligrams and they can use, and then when it hits a certain point, that's when I have to say, no, that's not pain management and that's not how we treat patients. So you have to go back to clinical indicators, functional indicators, but we don't want people to refuse to fill them, and we don't want people to just fill everything either. So I don't know how many physicians feel that they're bothered frequently because pharmacists are contacting them. I think if you're in a health organization or health maintenance organization, you probably get more of that communication. But that's something that we can take into consideration, is to give guidance about when you really probably should communicate with physicians. I think the law lays it out, but they are pretty open with their what the legal parts say.
Yeah, Dr. Kutzner again. One clarification, one question. Blind pain cocktails are not coup de grace, save the world, but they will help you in Merced or wherever you're at if you got a diversion patient. They are cleared by and governed by the California Code of Regulations. You should be intimately involved with the state pharmaceutical board. They can tell you, where to look it up. Now, going on with my question. We're talking about pain management here, and we're all these issues and people dying, etc. Anybody here belong to the current MTU or the previous MTUS committee? Please let me know. Raise your hand. Anybody here? Nobody up on the board. All right. The medical treatment utilization schedule is funded by you guys every year or every 5 years to review all the evidence-based medicine out there regarding pain management. Currently, they're doing that right now. There's like 22 gentlemen and ladies like you that are really good at this. And they go through all the evidence and they write down basic treatment guidelines. All right, now these treatment guidelines are every bit as good as Benika's book on pain management, etc. There's like 500-600 pages. And what I'm asking the committee here is, it is every year, every 5 years, it is a state law. It's a regulation, Title 8, Section 20, Section 9297.2. And it says, us providers shall follow, this MTUS guidelines. We don't, obviously, and nobody seems to enforce it. And look around the room, nobody even raised their hand saying they know about it. Why? What's up with that? We're spending lots of money, a monumental task that deserves lots of applause for Dr. Levine and everybody over there who are doing this, but it's not trickling down. The insurance adjusters are denying cases. The providers are jumping through it, and everybody's kind of out doing their own thing. Why is not the MQS being marketed, or why don't we know about it?
Any comments? Thank you.
The medical treatment utilization schedule is a law for guiding the care of pain patients in workman comp. Why is that information? It stops right at the state. They're doing it. It's remarkable. Other states follow it. Why is that information not trickling down to us so that we know and don't have all these questions for you? The citation is Title 8, Section 9792.2 to .26. It's a law. It says it's the authority. It also says providers shall follow, required. And it talks about everything you guys talk about. It talks about everything we know. If you know pain management and you go read it, okay, it'll be kind of boring to you. It's just same old, same old. But for those of us who don't know and we need guidance, the state's providing that. But somehow insurance adjusters and providers that get on NPNs, they don't know it. What's up? Why isn't it getting down?
We have about 2 minutes left, so we'll try to get your questions, final 2 questions.
Good morning. My name is Ken Shaw. I'm the Chief of Pharmacy at Rady Children's Hospital in San Diego. I've also had the honor to have served on the Board of Pharmacy here for 8 years. A question I have, and again, it's not about opiates, it's about stimulants. The stimulants are the issue that are my biggest concern. And I guess my question is, understanding that corporal punishment probably could get you a visit with CPS, but it doesn't seem to be a problem to drop a couple of Ritalin on your kid. How do the physicians manage that particular scenario? Because when they get to, a parent comes to a pharmacy with a prescription for like 1,800 Ritalin tablets, and the dad's a 250-pound mixed martial arts specialist saying, I need my prescription filled, more than likely we'll call you and you'll say, yeah, it's okay, this kid's got problems, and you fill it. From our perspective, how do we manage that situation?
All right, we have 2 minutes to answer that. Any comment?
I hope you have a glass barrier.
Who would like to tackle that one?
And no answer is a good answer, because then that helps me to determine how I advance next, because there may not be an answer. But again, we operate off of evidence as well, and our physicians. And it's something like a psychiatric issue. My wife's a kindergarten teacher, and she says, oh yeah, we got to put this kid on. I was like, wait a second, maybe just a good swift, smack on the bottom might work. But again, that gets you can't as physicians say that. You could get a visit as well from the medical board saying you're encouraging your parents to beat your child, which you're not. But again, it's okay to addict them on stimulants, or we don't even know if they're getting the stimulants.
Ron?
One thing real quick, if you get on there's a website called CogMed, and they're affiliated with the Karolinska Institute in Sweden. And they have a tremendous amount of material on alternative ways to manage attention deficit hyperactivity disorder in children and adults, but especially children. And they use they use 5% of the medicine that we use. And they use a bunch of other very, very simple, direct, and highly effective techniques for managing it. And they do not allow self-diagnosis. And they do not allow people to get stimulants on demand like we do too. Again, you need pictures of dead presidents, and you need to go to at least a few doctors, and you'll get all the stimulant drugs you want.
I want one last question. You've been standing patiently for an hour, I think.
Well, yes, Bill Holdick, family physician in Visalia, California. The question is, we've been talking about addiction, but there's not been a real clear distinction between dependence and addiction and how that's perceived. And my understanding is there are 2 separate processes, 2 different approaches. What is your suggestion?
Anybody? Close with that. addiction dependent.
The simplest way to think of addiction, I think, is just that when a person has an addictive disorder, not only there's a lot of aberrant behavior, et cetera, but when they get the drug that they want, it makes them worse. Bad things happen to them. They take the drug they're addicted to, and bad things happen to them, and they continue to happen as they take the drug. Physical dependency is a situation where if you take the drug away from them, they'll go into withdrawal. But when they're taking their drug, they don't have a whole series of catastrophic negative health, social, occupational, legal problems that happen to them. So I think that's one of the real simple ways to just think of the difference between dependency and addiction. Very few people that are only chemically dependent rob pharmacies. It's happened, but if they're only just dependent upon the drug physically, they're unlikely to engage in behavior like that. And that's an extreme example, but for another thing would be driving. There are people that are dependent that know they're not safe drivers, and they choose not to drive. The addict will drive no matter what.
That will end today's presentation. I want to thank the panel.
Thank you, panel of experts, and Dr. Winder. We appreciate this. Lunch is out in the lobby for sale. We're going to start right at 1 o'clock, so please be back in your seats. If you're interested in going off-site, there are some restaurants nearby, but we are starting at 1. Thank you.